right. Is everybody able to see the correct screen? Did I share it right? Okay, great. So I want to first thank everybody in the breast group for inviting us to give a talk on SBRT to the breast group. And so, you know, as a non-breast person, it's always great to be able to interact with folks outside one's area. And so, as Hannah mentioned, the focus of today's talk is going to be for SBRT for oligometastatic disease in breast cancer patients. And so, although SBRT is not that new within our field, and in fact, we've been doing SBRT at UWMC for decades. We just started doing SBRT at South Lake Union for a little just over a year. It's been going well. So it's a relatively new in-house resource for our South Lake Union clinic. Because it seems like we do have a wide variety of different folks here today, I thought it would be a good idea to just provide some background context by giving a brief overview of oligometastatic disease, and then moving into an overview of SBRT, and then really dig into some of the data that we have for SBRT for breast oligometastatic disease in particular. So in terms of the oligometastatic disease, OMD for short, it's a part of the spectrum, right? So on one side, you got localized disease with good prognosis, and typically we would go for aggressive local therapy as one of the primary treatment options. And then the other end, you've got the widely metastatic, poor prognosis, and really the important point is to give aggressive systemic therapy. And then, of course, you've got oligometastatic disease where it's somewhere, you know, in the middle, right? And it could be toward one end or the other end of the spectrum. So I think it's always good to talk about what does it really mean when we say oligometastatic disease. And the reality is, though, that it's a little bit unclear, it's a little bit muddy because, you know, in Latin, oligo means a few, but what does a few mean? And so, unfortunately, there hasn't really been a standardized definition. Different trials will use different definitions of how they enroll oligometastatic patients. In general, the prospective trials typically use the definition of less than 3 or less or 5 or less lesions. The question is there an upper limit? And perhaps is the upper limit that as many as you can definitively treat? Juxtaposed with polymetastatic disease, most people will agree that it's either more than 5 or perhaps 10 or more, but the definitions can vary. In terms of different flavors of oligometastatic states, these are, I would say, the general categories of synchronous, metachronous, oligoprogression, and oligopersistent. With synchronous, the key thing is that you have metastatic disease at diagnosis, and then metachronous is after diagnosis. And then oligoprogression, oligopersistence has a common theme in that overall the disease is stable, but that there's either isolated or very few lesions of progression, or that they're not responding, which is more of the persistence. But again, it's a lot more complicated than that. And so recently, ESTRO and the EORTTC groups have come up with a consensus recommendation on further classifying this. So it's a lot more complicated, right? So I don't want to go over like every single box here, but the point is that if you look at it, they further divide the types of oligometastatic disease states. And now you're talking about 9 different states. And all the trials that we have, there's probably a mixture in any of these. And so we will circle back to this toward the end, but just want to make sure that we convey it's very complex in terms of what kinds of presentations we actually see in patients. And so when we talk about, well, let's treat a patient in the oligometastatic paradigm, what are we really talking about? Well, it means that not only are we trying to take care of the primary, but we're going to aim at the metastasis with some sort of local therapy, and that typically is either with surgery, some ablative treatment, or radiation, and the thinking that doing so, it's going to improve overall outcomes. And so when we're talking about definitively treating oligometastatic lesions, we're talking about trying to ablate them. And so why would we do that? The way I kind of think about it is two main categories. One is to improve the progression-free and maybe even overall survival. And how is this accomplished? Well, decreasing the overall disease burden on top of what's being taken care of by systemic therapy. But I would say probably, at least in the GI world, is mainly what I do. One of the more common reasons why the patients are referred is that medical oncology wants to maintain the current systemic therapy they're on because it's working for 95+% of the disease burden in the body, but there is some bad actors, some bad children, so to speak, that they want to keep in line. And then we'll circle back to this, but is there any chance that there's going to be an abscopal effect? And one other thing that I think is poorly appreciated, and I think we need to do better at looking at and assessing, is how does this approach really improve quality of life? I think some prospective trials are beginning to look at this, but I think we're still missing a lot of data. But the point is that if we're going to improve local control, that we're actually going to also potentially improve tumor-related local symptoms like pain. But another an endeavor is to perhaps get patients off of systemic therapy with the assumption that there's going to be always some degree of side effects from systemic therapy. So if you can give them a holiday, that is something that's definitely worth shooting for. So in radiation oncology, we like to use a lot of acronyms. And so SBRT stands for Stereotactic Body Radiation Therapy, but people, I guess, want to do other things with their time and come out with other nomenclatures. And so the other common acronym that is used is SABRE. And so I guess it sounds more sophisticated than SBRT, but it stands for Stereotactic Ablative Body Radiation, which is the same thing. And I guess it sounds sexier because people think of a lightsaber, I think, when they hear that. For the purpose of this talk, I'm just going to call it SBRT because I'm more old school. All right. So what is SBRT SABRE? And I think before we dive into that, I think it's helpful because I think many people here don't have a lot of radiation oncology background, to kind of step back and talk a little bit about the basics, because that's going to help understand what SBRT really is. And so technology is something that's a big part of our field. And so over the decades, over the century, we've made a lot of progress in advancing our technology. So, I would say since the advent of CT scans, we've been able to do something called 3D conformal radiation therapy. And the goal is the same no matter what technology you use, is that we want to treat the tumor, but spare the surrounding normal tissue, as you can see in those two circles. And so what 3D conformal really is using 3D information through CAT scans when we do our simulations to outline our area. In this case, it's the pink tumor. And then we just shape the radiation beams in however many we want to do so that we can treat the tumor in a conformal way. And because I'm a GI person, I'm going to show you some GI pictures for now. And so this is an example of a hepatocellular carcinoma using essentially a 3-beam approach where we're shaping in a box-like fashion the tumor of interest. But we've evolved beyond that, and now with sophisticated hardware and sophisticated software within our treatment planning systems, we can leverage the power of computers to do more than just shape the radiation using kind of boxy kind of conformality. And so with IMRT, which stands for intensity modulation therapy, we can further minimize the normal tissues that are being irradiated. And so I kind of like to explain to lay people outside our field is that it's kind of like playing with Play-Doh. You have a certain amount of Play-Doh or a certain amount of dose, but you can shape it however much you want to some degree. But the Play-Doh is always going to have the same amount of volume, right? So you're playing around and pushing dose around as much as you're allowed to. And so how this is we basically take the tumor and we're able to modulate the intensity of an area of the body with lower doses, higher doses. And then we do that for each field. And we do it in such a way that we almost create a topography, a three-dimensional dose distribution, much like a topography of land. And this is kind of so we can modulate the intensity spatially. And we do this using sophisticated sort of equipment. We can, using leaves, kind of move in and out and control the amount of doses in, different pixels within the tumor. And so this is an example of a liver where we're able to better deliver conformal treatment and shape the radiation around the tumor. And so the next step is SBRT. And the way that I think about SBRT is almost like IMRT on steroids a little bit. We're further able to decrease the amount of normal tissue that is treated. And so this is kind of what I like to think. So instead of using maybe 3 or 4 beams, we can use many beams to converge on the radiation, and we can create high dose gradients of radiation dose around the tumor. And so this is an example of hepatocellular carcinoma where you can see that the concentric rings represent different doses of radiation, and we can really create really steep dose gradients. And so really the hallmarks of SBRT, how it's different than other things that we do, there's some key elements here, right? So by definition, we're condensing oftentimes many weeks of radiation into just 3 to 5 treatments. In the gamma knife world for the brain, it can be a single dose, but for outside the cranium, we typically will do either 3 or 5. So automatically that says off the bat that it's much more convenient for patients, right? Instead of having to come in weeks, they come in for a week, week and a half. But it's not just about the condense, it's about the high dose per treatment per fraction. So typically a single dose of radiation is up to anywhere from 3 to 10 times the amount of conventional fractionation. The number of gray per fraction, typically in the conventional world, it's 2 or maybe even up to 2.5, but it's usually up to 6, maybe even up to 20 gray per fraction, but typically within the range of 6 to 12. And so the intent is to ablate. It's not to keep it stable, not to shrink it, it's to get rid of it. And so even though the numerical dose may not seem very high, it does translate to a higher biological tumor dose. The other nice thing that it kind of gets into some of the reasons why we do it is because in instances where we typically would have to add concurrent chemotherapy to radiation when we do it conventionally, there is no need for that anymore because the doses are so high, so ablative that it removes the need for concurrent chemotherapy and all the toxicities associated with the concurrent chemotherapy. The other hallmark is that we're creating really hot spots. And so even the dose that might be on the prescription, in reality, the dose, the tumor is actually getting even much higher doses than that because we're able to put in hot spots within the tumor and create really high dose gradients, which you can kind of see here in the picture. The other hallmark is because we're giving such high doses, you have to be ultra precise. And so we like to say that with SBRT, we're giving treatment with millimeter accuracy, okay? Which means that there are things that we do that are that much more important than usual, right? So we have to make sure that patient doesn't move, that we have good immobilization, and anything that might move. So motion management is absolutely key because if we're trying to be millimeter accurate, we don't want to miss. So which goes hand in hand with that is that, well, yeah, we want to make sure that we manage all these uncertainties with motion, but the hallmark also is that image guidance and precise image guidance is that much more important. So all of these things kind of add to the work, and I guess why you can argue that why it's technically challenging, and you can't just do it. You need to be able to develop a program that requires a whole team effort between the physicist, the therapist, and the dosimetrist to be able to execute all of these hallmarks of SBRT than the typical conventional radiation approaches. So the question is, well, how does it actually work? Does it work any differently biologically than if we were to give the radiation much slower? The honest answer is that we don't actually really know. We have hypotheses on why SBRT might be different. And so just with any radiation, there's always going to be some direct tumor cell killing by the virtue of injuring the DNA and damaging the DNA of the tumor, and therefore causing death, cell death. But perhaps because we're giving the radiation so fast, so much, that there's other mechanisms at play here. And so one of the theories is that in addition to the tumor cell itself, that we're somehow affecting the microvasculature that the tumor is relying on. And perhaps it's causing vascular collapse and therefore tumor cell death. Even a little bit more hand wavy, but is of interest, there's a lot of work looking into it, is perhaps it's acting as a augmenter of the systemic response through the immune system. We'll talk a little bit more about that, but basically being able to unmask the tumor antigens in a way such that if patients are on immunotherapy, that it could make the immunotherapy more effective. So why would we want to do it? So I think of three main reasons why we want to do it, as opposed to, say, other means of radiation, or perhaps even other means of local directed therapy. Radiation, as you all may know, that it's completely non-invasive, it's completely painless, it's an outpatient procedure. So it has some benefits over other more invasive ablative treatments. The data which we'll show you is that it's well tolerated. We like to say that if we're seeing a patient on treatment for SBRT, there's nothing much to talk about because they really don't have much to complain about. Late toxicities are a little bit different. We'll talk to a little bit more, but acute toxicity is night and day between putting a patient on for a few weeks of treatment. And the reality is that the data shows that it's quite effective. Local control, most studies will quote anywhere from 85 to 95% local control. And so there have been one of the more recent systematic reviews and meta-analysis done in the past year, looking at several studies. And across the board, if we look at acute toxicity on the left here, you can see that most of the studies report, less than 5% for sure, and probably even closer to less than 3%. Same applies for late toxicity. There are some studies, and Christine will talk more about some of the other studies that maybe show a little bit more than we would expect. But in general, most of the studies show that late toxicities are rare. And then it's effective. And so if we look at just 1 year local control across all studies, we're talking about 95% local control. But local control isn't the only thing, right? So when we talk about efficacy, we talk about, well, if we're also treating to manage tumor-related local symptoms, how good are we? And so this is a randomized phase 2/3 trial from Sunnybrook, where they randomized between conventional radiation, basically 20 gray and 5 fractions, which is probably one of the more common palliative regimens that we'd use, versus more an ablative regimen. They did 12 gray times 2, so a total of 24 gray to bone mets in the spine. And what they found at 6 months, and that's a reasonable time period to look at, that the complete pain response was statistically not even close. It doubled the amount of complete responders. So I'm going to turn it over to Dr. Fang, who's going to talk specifically more about what this all means for breast cancer, because she's much more of an expert at this than I am for breast cancer. So Christine, I will stop sharing.
All right. Thanks, Jim. You guys all see my screen now? It should look just like Jim's was. Okay. All right. Well, thanks again for having us today. And Jim is the expert in SBRT. Just to be clear, I learned a lot from putting this talk together. So I'm glad I had the opportunity. All right. So I wanted to start with just one of the cases that we treated actually early last year when we were just starting up our program. So this was a 50-year-old woman that had a T2N1 invasive ductal of the left breast. It was grade 2, ER positive, HER2 non-amplified. And she went on to a left mastectomy and a sentinel lymph node biopsy that found 2 positive nodes and a right prophylactic mastectomy. Her mammoprint was high, so she went on and received chemotherapy as well as radiation to the left chest wall and regional nodes. And all of this was done on the outside. Little bit unclear. Oh, she started tamoxifen, and 2 months after finishing radiation, she got a CT scan, not totally clear exactly. I don't think she was having any symptoms, but they got this CT of the chest, abdomen, and pelvis, and it showed a lesion in her 9th rib. And so I'll show you that here. It's sort of in the posterior portion of the 9th rib near the spine, and a bone scan also confirmed this finding. Okay. So the rib lesion was biopsied and confirmed to be metastatic disease. She, again, a little unclear, but she got switched from tamoxifen to anastrozole, but then was presented at our tumor board and had imaging review that showed she didn't have any other sites of disease that were concerning. And so our decision was that she should be evaluated and assessed, and then we felt that she was a good candidate, appropriate candidate for SBRT to the rib lesion. So we simulated her and came up with a really nice plan. This, I think, is a good example, what Jim was saying about just how important it is when in terms of precision and the millimeter accuracy. You can see that we're really close to the spinal cord, right, the spinal canal. And so it's really important that we do not get any of the high dose ablative doses in the spinal canal. Okay, so patients are imaged, before every treatment, right before the beam is on, to make sure there aren't any adjustments, and so any of those millimeter adjustments get made right before treatment. And so this was a really nice plan. You can see just how conformal the doses are. The prescription here was 600 or 6 gray times 5 fractions that was delivered sort of every other day. So patients usually get done over a period of about a week and a half. And so this is just another picture showing that. Okay. And so what do we know about oligometastatic disease in breast cancer? Well, when we look at some big phase 2-3 trials for metastatic patients, about half of those patients present with 1 to 2 mets. So by definition, oligometastatic disease. And in general, when we compare metastatic breast cancer with other histologies, right, we know that in comparison, they do have a longer natural history and better prognosis. The more common sites of metastases are to the bone, lung, liver, brain. Those are sort of the top ones, and then sometimes the adrenal as well. And most commonly, we've treated these oligometastatic sites with either radiation, with surgery, and for liver lesions with RFA as well. And just to give a sense of, well, how much is SBRT being utilized in oligometastatic disease? There was a survey that was done for over 1,000 patients or 1,000 radiation oncologists, and showed that over 60% of them were already using SBRT to treat oligomets. And the remaining radiation oncologists, over half of them said that they were planning to do so in the near future. So it is something that is being really utilized currently quite a bit already. This is a busy slide. I just wanted to point out what Jim has already mentioned, which is that, when we have a list of the studies we have so far, if we look at overall survival of patients that have oligometastatic disease and breast cancer, that patients, do well considering they have metastatic disease, right? I mean, their overall survival in some of these, there's mean, there's 2-year. Some of them look specifically at ER positive, and we're looking at 6+ year median overall survival. There's a study that I'll go over in just a moment here that shows us something that I think all of us already know, which is for women that have bone-only disease, that they can have really many years of additional time once they've been diagnosed with the metastatic disease. So I'm going to spend probably the majority of my time on SABR Comet, which was a study that was presented, I think 3+ years ago now, but received a lot of fanfare, and one I think that we should all be familiar with, sort of the nuts and bolts of. It was a phase 2 trial, okay, and it accrued 99 patients over a 4-year period, so 2012 to 16. It took patients from 10 centers across 4 countries. And the eligibility for enrollment was that the primary tumor had to be controlled and had been treated definitively. Patients had 1 to 5 metastatic sites that were all treatable by SBRT and could only have a maximum of 3 lesions in a single organ. All these patients had a good performance status, was expected to live for at least 6 months, and biopsy was not required, but was preferred. And so patients were randomized to the control arm, which was just sort of standard of care, palliative treatment, whether with systemic therapy or with radiation, or the experimental arm, which was, in addition to the standard of care, also SBRT to all of the metastatic sites. Systemic therapy was given at the discretion of the med-onc. And in terms of what patients enrolled, well, about 18% were breast, and then we have the other 3 basically most common cancers, right? The top 4 cancers are listed basically right here. And these are some common fractionation schemes. So you can see it could range anywhere from 3 or 5 or 8 fractions. And this table just shows where these mets were, and the majority of them were either in the bone and or the lung. And I just wanted to point out something that I think is important when we're reading sort of any study, which is, sure, the eligibility was 1 to 5 mets, but the reality is the study enrolled the vast majority, right? 93% of patients actually only had 1 to 3 mets, okay? And so when we're talking about how we apply this in the clinic, I think it's important for us to just remember this. Not to say that if we see 4 to 5 meds, we shouldn't consider them, But in SABRE comment, really, it was ended up being really 1 to 3 lesions. And so what were the results? Well, we now, initially it was 2-month follow-up, or 2-year follow-up, but now we have 51 months of follow-up with the most recent updated publication, and that shows there's a clear improvement in overall survival with a median overall survival of 50 months for those that received SBRT versus just standard palliation, so 28 months. And then with progression-free survival, also a significant improvement at 12 months versus 5 months. Now, it's important, of course, for us to know what's the cost, of treating with SBRT and what are the side effects. Jim mentioned earlier that SABRE comment did show a bit higher risk of side effects compared to some of the other studies that are out there, but it did show here grade 2 or greater adverse events, 29% versus 9% in the control group. Okay, and there were 3 deaths in the SBRT arm. Okay, and so these were sort of the 3 reasons attributed as radiation pneumonitis, an abscess in the lung, and then the third one was a patient had a subdural hemorrhage after a surgery to repair an ulcer. Okay. I think another really important takeaway from SABRE comment was that when patients were took the quality of life surveys, that there was no difference that was seen, meaning that that SABRE was not detrimental to quality of life, that it did not lead to sort of chronic side effects that then affected quality of life. Now, it would have been nice to see an improvement, but we know at least the treatment did not decrease their quality of life. So now, so that's really sort of the best study we have right now. It's randomized, it's not a breast-only trial, but it is sort of the basis of what a lot of what we do now. For breast only, what's currently available are some prospective and retrospective studies, and I'm going to go over these fairly quickly. And I think sort of the value of these studies really is you can sort of take a tidbit of information from each of them that then goes to our sort of collective understanding of what we know. And so this Italian prospective study looked at 54 breast patients that had a total of 92 lesions that were treated. And really, I think the takeaway on this one is that the progression-free survival was decent, and that there were no grade 3 or greater toxicities. Okay, and so appears to be safe and effective. The next is also a prospective study out of the University of Rochester that looked at 48 patients. And I think the important thing about this study is it confirms again something we already know, but gives us a magnitude of how much better do bone-only patients do, right? And this sort of had a longer term follow-up because it looked at patients that got treated as early as 2001, and bone-only women had 10-year overall survival of 75% when they had received SBRT to those lesions. Okay. We've got a German retrospective study, again, looking at about 46 patients. And although it was a very big sort of time range from 2002 to 2019, the majority of these patients were actually treated in the last couple of years of the study. What I want to point out in this one is something that Jim already mentioned, which is that really the local control in the areas that are treated is really excellent, and usually in the in the ballpark of about 90%, right? 90-95%. Okay. And then this last publication I'll bring up here is was a pooled analysis from 8 different sites. So it included Duke, Vanderbilt, UCSD, Mount Sinai, or some of them. And they took basically all the consecutive patients that had been treated with sort of a definitive intent to the Mets. And of the 361 of those patients, 58 were breast patients. Okay. And here they did a lot of sort of univariate and multivariate analyses, and the multivariate analyses showed that breast cancer was a predictor of a superior progression-free survival, as well as number of involved organs. Liver mets actually had was a poor predictor of progression-free survival, as well as prior chemotherapy was the other direction. But like I said, I mean, we sort of get little pieces of information from each of these studies. So I'm going to move to, you know, what again Jim mentioned already, which is what is that? How does SBRT and immunotherapy potentially work together, sort of synergistically? So these ablative doses, right? The idea is these ablative doses release cytokines that then recruit anti-tumor lymphocytes. And there are mouse models that show that when you give this ablative radiation, that it does improve the effectiveness of that anti-tumor immunity. And so there's been some nice successes in melanoma and in lung cancer we've seen so far. And there are lots of trials going on right now looking at the combination of immunotherapy with SBRT. There is an Australian study that looked at a single fraction of SBRT with Pembro in oligometastatic breast cancer specifically, and that study has closed. So we're sort of eagerly awaiting the results from that study.
I think we'll switch gears if you unshare, and I will see if I can do this correctly again. Okay. All right, so I wanted to share a case example that actually Jen Speckman and I shared. And so just kind of, you know, we all hear about it, and I've seen it one time, and this is the only time that I've seen it, and it actually was in a breast cancer patients. And suffice to say that most of the time that it's reported, it is in highly immunogenic cancers like melanoma and non-small cell lung cancer. But this is an example. It was very interesting, even though it wasn't durable, but it does show you the potential effect. So it's a 29-year-old female who had left triple negative breast cancer, got neoadjuvant AC chemo, got surgery with a modified radical mastectomy, then got modified radical mastectomy radiation, got put on Pembro, and then had diffuse widespread recurrence in the bone, in the right cheek and lymph nodes, particularly in the mediastinum, as well as a severely symptomatic metastasis that's involving the left shoulder muscles, the trapezius, the supraspinatus, and the scalene muscle you can see there. And so was sent to me because she already had prior radiation. And so initially it was to consider SBRT, but I didn't feel comfortable with SBRT with all the critical structures like the brachial plexus. So we did something like an SBRT-like, so slowing it down a bit, not going as fast as SBRT for safety. And this took place about 3 months after Pembro was initiated. And so we treated 4 grade times 9. And after a month, there was a near complete response in all sites of disease. She got put back on Pembro, and then at 3 months post radiation, as you can see here, she had a complete resolution of her mediastinal nodes, which we did not touch. And she was on Pembro for a while, so the thinking is that maybe radiation did have some sort of a role here. And this shows an example that in that 3 months post treatment, that the area which was quite infiltrative had a complete response to radiation, though she eventually did have recurrence of this area. And so My understanding is that I think she is still alive. And so I think I want to spend just the last few remaining minutes about, when we think about SBRT, when should we do it and who should we do it in? And I think any surgeon will appreciate this quote from Dr. Blake, which is biology is king, but the next most important thing is selection of cases. And all the other fancy stuff with SBRT, we're just a prince or a princess, right? And so the question is, how do we best select for patients? And so there's some data that suggests that perhaps patients that would most benefit from SBRT are those that has had a disease-free interval relatively long, 1 or 2 years, and that they are truly a limited number of Mets. And so this is some data. Again, this is not breast specific, but some data to actually show that perhaps the disease-free interval does matter. So when they looked at patients from Japan and China, where if patients had greater than 1 year a disease-free interval, that the 3-year survival was in the 50% range, as opposed to if it was less than a year, it's twice as less. So perhaps, we want to select for those that have good biology. I think this is basically what it's saying.
Right. So how you're going to do is how you're going to do.
Yeah.
Exactly. So this is a clinical judgment issue.
Yeah.
But I think it would be great if you guys could help us, sort of come up with a bit of an algorithm here, so that we can think about it and some institutional guidelines. I hope we can look at this from a research standpoint and do a bunch of exciting things. But I think that there is potential to really use this very, very inappropriately. Like take somebody who has widespread metastatic disease, get a great response and get it down to 3 lesions and now call it oligometastatic and suggest that SBRT has a role, when I don't think there's any data to support that. But I think this is hard, and as our therapies get better, we're going to ask you to do more, because then the prognosis really does get better. And we've had a nice track record with the Gamma Knife team of really being able to help pick these patients. And we published something with them, which I hope we can do a similar thing with you at some point, that showed that, patients with great therapeutics do well and can even get re-gamma knifed. And who are those patients? Well, they're the ER positive and the HER2 positive patients. So no surprises.
Yeah, no, very, very good point. And I think there's just more data, again, showing that there's actually data that less number of Mets actually may make a difference when you go after these extracranially. And then as you mentioned, Hannah, that, there are data to support maybe it's the hormone receptor positive in limited organs. I want to spend a couple of slides on challenges. And this is something that I didn't really anticipate when I started to help the breast group do this with SBRT for extracranial lesions. I think the problem always is, again, going back to the patient selection, it's the tip of the iceberg problem. And I talk to patients all the time about this, is that we're making a lot of assumptions here, that we only see perhaps what's on the surface. And so this is a great paper published in Nature showing sometimes things don't work out as well as they could. And this is a patient with metastatic nasopharyngeal carcinoma, was treated with SBRT to the spine. And then literally a month later, the disease just exploded. And so in retrospect, it was worthless. It was not something that should have been done. And we just need to do better, perhaps with gene expression profiling. I also, something that I didn't anticipate as we're treating more of these and patients being referred, that we're running into more insurance problems with authorization than I have seen in other disease sites. And so this is a snapshot of the EVACOR guidelines. And this is specific to oligometastatic policy that they have, very restrictive. And so they would only approve it. So the good thing is that they do include breast at least, but it has to be a metachronous setting, not synchronous. So patient had no prior history of metastatic disease in the prior to this oligometastatic disease state. And so we're really talking about, we focus on those 9 states, they're only allowing 1. and they're not allowing any other, and so no oligoprogression, no synchronous. It's just one little box here, so it's very restrictive. And so that's some of the things that we're seeing. So it's just to be transparent to the rest of the group, is that we are running into insurance authorization issues with the breast patients. And then lastly, where do we go from here? I just want to show this. There's a lot going on, as Christine mentioned. These are all the active breast-specific SBRT trials, so there are a lot. And then there are even more that include breast patients. And then finally, Christine can talk a little bit about the energy study.
Yeah, so the energy study is a randomized phase 2/3 trial. The phase 2 portion actually has been completed, looking first to define the progression-free survival, and then once that data has matured, then we'll be moving on to the phase 3 portion. The phase 2 accrued 128 patients. Phase 3 is going to be like 230 patients, but basically looked at women that had less than 4 sites, 4 or less sites, I guess. The primary disease again was controlled and was diagnosed within a year, the metastatic disease, when they were getting the treatment. And so they're going to be again randomized to sort of standard of care, so systemic therapy with palliative therapy if necessary, versus SBRT to all the sites, or I guess they could also have metastatectomy with surgery. And the really interesting thing here too is they'll be looking at detection of circulating tumor cells at baseline, after treatment, as well as at progression, to see if that's going to be a biomarker we can use to identify who's the most appropriate patients in the future for SBRT.
So I think this is a summary of kind of all we talked about, but I think Christine and I both want to emphasize that yes, ideally we should be enrolling these patients on a clinical trial because there's a lot that we still don't know. But I think with the group that you guys have, I think it's a good forum to really sit down and discuss which patients might benefit, because I think even if we don't have a clinical trial to enroll these patients on, I still think there's still some clinical benefit with I think the data that we do have. We could definitely use more, but that all starts with kind of discussing, and we haven't really sat down and talked about creating a standardized algorithm, but we can certainly, I think, with Janice and Waylene and Christine, I'm sure could come up with one, and I'm always available to kind of chime in as well. And so that's the end. Thank you for having us.
Yeah, thank you.
Thank you for tackling this, you guys. This is a tough one, but I think working through to have some algorithms would be very helpful. And I appreciate you bringing forward the insurance issue, because the idea that the patient has to pay for it or has to be the bank and pay for it while you push for approval is really not in the realm of what we want to be doing. That's not fair to the patient, and really creates obvious disparities. So I really appreciate you bringing all this up. I know Habib has left, but he had a question for you about the vascularity of tumors and whether it's the more vascular tumors with peripheral enhancement that actually are more radiosensitive.
So I don't think necessarily we have data, other than the fact that we have data on solid tumors that historically are just more radiosensitive. So I give you an example in my world. So if we're giving SBRT to a hepatocellular carcinoma, which is inherently very vascular, and then giving it to a liver met, which is hypovascular, the data shows that the more hypovascular tumors, and it could just be other reasons why they're less sensitive to radiation, but the local control isn't 95%. It's closer to 70, 80%. And so I think the way radiation works, despite what we're saying about other ways it might kill, I think still depends on oxidative damage. And so we need oxygen, I think, still.
And I don't know if you guys can see the chat, but Rachel was asking if we could do palliation using this strategy, or are you still recommending whole beam?
Let me see if I can see the question.
And I think that SBRT does offer palliation, certainly, right? So if patients are symptomatic to that oligometastatic site, that we do expect that there would be a palliative effect. But whether or not we would use SBRT when the I guess the goal is palliation only, right? I mean, when we're treating for metastatic disease, it's because we sort of had this curative intent, right? We're trying to take care of all the disease. I'm not sure if that answers your question, Rachel.
Yeah, I'll chime in too. I think it's case by case. I already showed you that data from the spine met data, that trial, you know, one of the endpoints, primary endpoint, was just pain control. And there was a clear benefit if you were to be more aggressive with the dose. So it kind of depends, right? So if you're a patient that poor prognosis, poor performance status, 6 months later, does it really matter that they're going to have a better pain control? But as opposed to someone who's going to be around for years, you don't want to have to deal with this site again. And so might as well just deal with it and get rid of, try to do your best to have a complete response, because they're going to be around for a while. So I think it's a clinical judgment, whether for pure palliation, whether you want to be aggressive with the dose or not.
Right, and then sort of related, but a little bit different, is Ellen's pushing on that scenario where you have a HER2 positive patient who has widespread mets, and then, you know, you get this fantastic response, and some of these patients just do incredibly well. Is it reasonable to consider them as oligometastatic once we've effectively debulked them?
Yeah, you almost have to go to the crazy algorithm about where they would fit. And so, you know, Evacor will point out that there's very little data for oligoprogression in this space. So I think that would likely fall under the what they call induced oligo progression. And so, you know, I just don't think we know enough. We certainly will go after oligoprogressive disease because clinically sometimes it makes sense. I think an easier case would be like, it's just one spot and that's the only spot there is,
right,
despite that they had a polymetastatic picture. What do? Do you just say, okay, we're going to keep on doing systemics until whatever?
Right.
And so those are, again, we're not going to have data for every single one of those 9 subsets. There's just no way, right? And so I think this is where it has to be clinical judgment, you know. Yeah.
And to
Right,
answer,
well, we're really hoping.
Yeah, I don't. Sorry, Hannah. I do not believe that in that setting they would be eligible for the NRG trial. Yeah. So
I think as long as you can show with first line therapy, if you can show disease stability, I think they are allowed, or they were eligible for NRG, because I think Steve Chamora had presented this at our last CME. So I think if you could show that there is some durable response systemically, I think they were eligible, but I can go back and look, because I think those are the people, if you could clear their disease with first line systemic therapy for metastatic disease, those are the ones you actually want to try and see if you can get control with SBRT.
All right, thank you everybody for coming together here. Really great topic, really appreciate that. Jim, you're here, and Christine, you're interested, and we're trying to move this forward. I really appreciate it. I think it's a great advance for our patients, and thank you for taking the time.
Thanks for having us.
yeah.